I'd like to introduce our first speaker, who will be covering anticoagulant-associated bleeding and enemy hiding in plain sight. So please welcome Christian Ruff, who is a clinician, a cardiologist from our TIMI research group at Brigham and Women's Hospital and Harvard Medical School.
Great, thank you everybody, and welcome. It's a pleasure to share the evening with you talking about an important topic, and there's been a lot of developments in this field. And I'm just going to broad overview on anticoagulation-associated bleeding. These are my disclosures. So learning objectives for today, first to evaluate the anticoagulant-associated bleeding risk, particularly comparing warfarin with the new drugs, the NOACs or DOACs. To outline our current risk assessment for bleeding and how that's inadequate and we need a better one. To identify drug and patient-specific factors that drive bleeding risk, which is critically important. And to illustrate how patient comorbidities often lead to undertreatment, which is a serious problem worldwide, but particularly in the United States. And to propose modifiable opportunities to mitigate bleeding risk. And later talks will sort of involve treating bleeding and particularly the excitement around specific reversal agents, but obviously preventing bleeding is still of the utmost importance. And we know that this was a challenging field for half a century because warfarin up until 10 years ago was the only oral anticoagulant approved for human use, literally from 1954 to the late 2000s. And we've always known that it's been challenging because although warfarin's highly effective in reducing ischemic stroke, it comes at a penalty of increased risk of serious bleeding, particularly intracranial bleeding. This is a famous graph of the narrow therapeutic window of warfarin from Elaine Heilich at MGH at the time and now at BU, showing that unless you keep the INR closely between 2 to 3, you don't optimize the risk reduction for ischemic stroke. And if you're above 3, certainly 3.9, that you begin to have an exponential increase in the risk of intracranial bleeding. And remember, intracranial bleeding associated with an anticoagulant has a case fatality rate that's close to 50%. So there had been intense interest in pharmaceutical companies and academic labs to develop alternatives to warfarin, and I'm not going to go through the individual trials, but their two main indications are for stroke prevention and atrial fibrillation, and treatment and prevention of venous thromboembolism. And in general, the NOACs, and this is for atrial fibrillation, are highly effective in reducing ischemic stroke, about as good, if not better, than warfarin, but are vastly safer with respect to bleeding in the brain. In fact, associated with about a 50% reduction in bleeding with the brain, which is an incredible advantage, and that's thought to be how the drugs work. Warfarin is a very sort of promiscuous anticoagulant, and it interrupts the anticoagulation cascade at multiple factors, including factor 7. And factor 7 is where tissue factor enters the coagulation cascade, and your brain is basically covered in an envelope of tissue factor. So if you have a bleed in your brain, you get massive tissue factor upregulation. If you're on warfarin, though, you have a hard time because you've interrupted factor 7, where all of the NOACs and the number ordering doesn't quite make sense, but because they're factor specific at factors 10 or 2, it's thought to be that you can sort of overcome if you have a bleed in the brain, you get massive tissue factor activation. If you talk about major bleeding in general, you don't quite see as robust reductions, but in general, you see about a 14% reduction in major bleeding, although you do see an increase in GI bleeding, and that's also due to how the drugs work. Warfarin's an inert substance in your intestines, so all the bleeding you see on warfarin, including GI bleeding, is due to systemic exposure of warfarin in the blood. Not that you don't get bleeding from systemic exposure to NOACs, but you actually get local anticoagulant effects of NOACs in the gut because they're actually active, so as they go by a tumor, a polyp, or an ulcer, you'll actually get local anticoagulant effects. But because they're far safer with respect to serious bleeding, about a 50% reduction, actually NOACs lead to about a 10% mortality compared to warfarin. But it's very important that there's still a concern for bleeding with the NOACs because, as I mentioned, that although you cause 50% less intracranial hemorrhage with NOACs compared to warfarin, if you happen to have an intracranial bleed, either on warfarin or a NOAC, your outcomes are terrible. And these are case fatality rates from one of the large stroke prevention and atrial fibrillation trials, apixaban versus warfarin in the Aristotle trial, that the case fatality rate, if you had an anticoagulant-associated ICH, was about 42 to 45%, regardless of which anticoagulant you had. So clearly, bleeding is still a significant concern anytime you're using an anticoagulant. The data for VTE look fairly similar. Again, these drugs are highly effective compared to warfarin, but where they really shine is their safety. In the VTE population, which tend to be a good 10 to 15 years younger, you see less major bleeding. You even see less GI bleeding. Why is that? Why do you see more GI bleeding in the AF population and less GI bleeding with NOACs in the VT population? That's because these patients, as I mentioned, are 10 to 15 years younger. They don't have peptic ulcer disease. They don't have other reasons to have GI bleeding. And of course, you see these significant over 50% reductions in fatal bleeding. So anytime you're using an antithrombotic, and this is really true for anticoagulants or antiplatelet agents, you're really trying to balance two important but competing risks. These patients are at high thrombotic risk, and you want to provide them antithrombotic protection, but anytime you prevent clotting, you can cause bleeding. And for an individual patient, you're trying to find the sweet spot, both with respect to their individual risk of those two events, but also which drug that you're going to select. And it's important just from an epidemiologic perspective, if you're prescribing anticoagulants, how frequently are you going to see particularly a major bleed? And a little bit depends on the population. For the AF population, so if you're anticoagulating a 70-year-old, your major bleeding rate's going to be somewhere around 2.5%, 3% per year. The majority of the bleeds that you're going to see are GI bleeding. And again, because NOACs really aren't better than warfarin, in fact, you tend to see more GI bleeding, that's the most common type of bleeding that you're going to see. Intracranial hemorrhage is terrible, but it's relatively infrequent. Even with warfarin, the annual rate of intracranial hemorrhage is about 0.5% per year, or 0.6%, and it's half that with the NOACs, so vanishingly rare. And with the VTE population, because they're younger, bleeding rates tend to be about a half or a third. But again, GI bleeding represents the most common type of bleeding that you're going to see. Another issue, obviously the most important, is patient mortality and morbidity with bleeding. But of course, these are also expensive to our healthcare system. They're things that we'd like to avoid. A little bit differs the cost depending on what type of bleed. Intracranial hemorrhage, the most expensive, about $40,000. Major GI bleeding is actually fairly close to that. And so we can see if you have a major GI bleed on an anticoagulant, you're looking at somewhere about $50,000 per bleed. So these are significant costs to a healthcare system, especially when you consider how many patients we have on anticoagulants. This issue about bleeding is also incredibly important because it factors in whether physicians or patients take anticoagulants. And we know in our updated U.S. registry, and this is the NCDR Pinnacle Registry for atrial fibrillation, that no matter what your CHADS-VAS score is, so even very high-risk patients with CHADS-VAS scores of 8 or 9, only about 50% of patients are prescribed an anticoagulant. So even though a third of strokes, the atrial fibrillation, if you're not on an anticoagulant, are fatal, we're still not prescribing it to upwards of 1 in 2 of patients we encounter in clinical practice, even high-risk patients. It's a little bit hard to figure out why physicians make these decisions. Oftentimes we don't know, but in another large international registry, the Garfield Registry, when you ask physicians why they chose not to prescribe an anticoagulant, the most common reason that they cite is bleeding risk, fall risk, which usually they're worried about bleeding if the patient falls, and only really a small subset of them did they feel like the patient actually didn't warrant an anticoagulant, it's just they felt it was too risky to prescribe it. One of the issues that gives physicians a lot of concern is, how are we able to assess a patient's truly at a high risk of bleeding? There was a score, we have the CHAD score and the CHADS-VAS score, very popular. So of course everyone wanted to have a bleeding score, and for a while there was this bleeding score that was out there, the HASBLED score, and you see it's an acronym, right? You get 1 or 2 points for hypertension, abnormal kidney or liver function, prior stroke, bleeding, labile INR, drugs, which are really antiplatelet therapies, or alcohol and age.
But the problem with this score is many of these same factors, look, hypertension, age, stroke, those are stroke risk factors. And so if your patient's at a high risk of stroke, they're also going to be at a high risk of bleeding. And so you're identifying the same patients. And in fact, the reason why no one is supposed to use the HAS-BLOOD score anymore, and it's actually been dropped by every major guideline in the US and throughout the world, is if you actually took a patient in your clinic and you measured their CHADS-VAS score and your HAS-BLOOD score, you can actually never find a patient, statistically at least, where their risk of bleeding on the anticoagulant outweighs their risk of having a stroke. And this is here in the top left corner, you see patients with a CHADS-VAS score of 0 or 2, so low risk of stroke, and a high HAS-BLOOD score of 3 or greater. Even in those populations, low risk of stroke, high risk of bleeding, at least by the scores, there's still a benefit of anticoagulation. So it's not that you might not have an individual patient where you're able to make that decision, they're truly at a high risk of bleeding, but it just goes to show you physicians are terrible at estimating bleeding risk, and the HAS-BLOOD score provides no additional help. So people are desperately trying to figure out what is some risk factor or test that I could use that is exquisitely sensitive for predicting bleeding risk but not stroke risk. And there is some promise in this field. Just like we use biomarkers for everything else, you measure troponin to diagnose MI, you measure NT-proBNP to diagnose heart failure. There actually are emerging biomarkers that are very specific for bleeding risk. The most popular and studied is GDF-15. It's a measure of the TGF-beta cytokine superfamily. It gets elevated in oxidative stress and inflammation. And actually, it's uniquely predictive of bleeding, but not stroke. So patients who have an elevated GDF-15 actually are at substantially increased risk of bleeding, and it's actually now being incorporated into bleeding risk scores, at least for atrial fibrillation. The most common one is the ABC bleeding risk score, and we're likely going to see this first in the US, in the European guidelines in this year, and probably will be adopted by the US guidelines next time they're rewritten. So I think we will have blood tests that if you see a patient in clinic that you think is at a high bleeding risk, that you may be able to measure a GDF-15 or something like it to tell you if that patient's at high risk. We know that if you're seeing a patient, it's often the patient with comorbidities that you're not treating. We know that in an elderly population, at least 40% of patients there on the left are deemed frail. And if you look at those frail patients and you look at whether physicians prescribe an anticoagulant in the elderly, and they're defining that as 75 or above, 70% of patients not receiving an anticoagulant. If you have ischemic heart disease, 70 patients not receiving an anticoagulant, et cetera, diabetes, renal function, always about 70 to 80% of patients with thought to be vulnerable risk factors are not prescribed a blood thinner. Frequently, you'll hear that patients who had increased risk of falls shouldn't be prescribed an anticoagulant. We actually measured this prospectively in one of the trials, and we actually took patients who had previously fell or were at risk for falling. They had balance issues and et cetera. And bad things do happen to them. They do fall. They do tend to have bone fractures. They do tend to have bleeding. But interestingly, here is where in particular, the NOACs had the greatest benefit. Because as I told you, the major benefit of NOACs is they're far safer with respect to serious bleeding. And elderly patients who fall have very high stroke risks. So you see here, look at intracranial hemorrhage, which is the ICH in that second bar. If you have a patient not at risk of falling in the blue, your number needed to treat is 257. And so although you lower the ICH risk by 50%, because patients who don't fall don't have a lot of falls and intracranial hemorrhage, they're relatively healthy, that you need to treat a lot of patients before you prevent one intracranial hemorrhage. Doesn't mean it's not worthwhile, but that's how the math works out. Where a patient has increased risk of fall, because their risk of intracranial hemorrhage is higher, you only need to treat 57 patients with a NOAC to save one intracranial hemorrhage compared to warfarin. So I would argue in your frail and vulnerable patients, that's actually where NOACs shine the most. Thank you. What about kidney disease? Kidney disease is also an incredible marker of vascular fragility. And so we know whether you're talking about the atrial fibrillation trials or the VTE trials, if you have mild, moderate, particularly severe renal dysfunction, that you have substantially increased risk of bleeding. And so we have to be very careful about anticoagulating patients with CKD. And of course, in atrial fibrillation, there are particularly dose reduction criteria based on renal function. What confuses a lot of people is that there are no dose reduction criteria for VTE except for one drug, and that's edoxaban. And people think that there is some science behind it. There's actually not. The FDA approves whatever you put in your protocol. And all of the investigators in atrial fibrillation trials who were dealing with elderly patients, they incorporated dose reduction criteria in their protocol for patients with mild to moderate renal dysfunction, so the FDA approved the doses. The VTE investigators did not include any VTE dose reduction criteria in their trials, so the FDA didn't put it in their label, except for edoxaban, which was the one agent where the trial actually incorporated the same dose reduction criteria. So there's no scientific rationale for not dose reducing in VTE, but that's essentially the rationale for why the patch inserts are different. I will say particularly it's more of an issue for atrial fibrillation because these patients tend to have more renal dysfunction. A big issue is measuring their renal function. People want to know, I want to measure a drug level, I want to measure a 10A level. Those things are almost entirely useless in a stable outpatient population. If you want to measure one thing, measure your creatinine clearance, because if you don't appropriately dose reduce, and this is a study from a nice registry, Medicare, that you will actually increase the risk of bleeding by about 2.2 fold. And so the one issue to avoid bleeding is appropriately dose reducing in patients who have mild to moderate renal dysfunction. Another big issue for bleeding is combination antithrombotic therapy. No matter which agent you have, warfarin or a NOAC, if you add one antiplatelet agent, you'll increase the risk of bleeding by 50%. If you're on two antiplatelet agents, you'll increase the risk of bleeding by 250%. So there's not a lot of patients who are going to tolerate long-term combination therapy. So one of the most important things I do in my practice is drop aspirin or other antiplatelet drugs unless a patient clearly needs it. And we know up to 40% of patients on an anticoagulant are also on aspirin completely inappropriately for primary prevention of coronary disease, which is not indicated. This is, of course, more complicated in patients who have recent acute coronary syndrome and stenting, where we do have to use combination antithrombotic therapy. And this is a very nice meta-analysis, and the bottom line is basically triple therapy is dead. Almost no patients can tolerate aspirin, a P2Y12 inhibitor such as clopidogrel, and an anticoagulant, whether that be warfarin or NOAC. And most patients now with coronary disease and atrial fibrillation or VTE should just be on a single antiplatelet, usually a P2Y12 inhibitor such as clopidogrel, and the anticoagulant alone. So to conclude, I'd like to say that we have vast repository of data that NOACs are at least as effective and far safer compared to warfarin for both AF and VTE. The fear of bleeding is certainly a major factor whether physicians decide to prescribe anticoagulation. We do need better tools to accurately predict bleeding risk, but I will say we've come a long way, and we now have emerging biomarkers that will help us. Patients with comorbidities, as in all other things, are frequently inappropriately undertreated, and that's a real miss because these patients derive the greatest absolute benefit from anticoagulant therapy, particularly with NOACs. And there are a lot of opportunities that exist to mitigate bleeding risk. So we're going to hear a lot from the next speakers about treating bleeding, but I would argue the best management strategy for bleeding is preventing that bleeding from ever occurring in the first place. Thank you for your attention.
Yeah, so we're going to take questions at the end of the program, so open up your cell phones and post them. But let me ask you one question. So clearly bleeding is less frequent with the newer agents. They're safer in the frail patients. You have this new biomarker that we can use. So if I'm a patient in the audience and I'm on warfarin, what should I be telling my physician?
Yeah, no, it's a great question, and I think, there are certainly reasons, for patients who haven't had bleeding on warfarin or who have steady INRs and a good time in therapeutic grade, and there's certainly less potentially advantage from switching to NOACs, but it's interesting that even patients on warfarin who have well-controlled INRs, the benefits of NOACs seem to be consistent on a relative basis compared to warfarin. So I think even in patients well controlled on warfarin, there is potential benefit, particularly on the safety side, for switching to NOACs. I do think for people who are concerned for bleeding,
it's important to remind that the risk of stroke almost always outweighs the risk of bleeding. And that test I mentioned is available to be measured, but it's not ready for prime time in clinical use. But actually, I was at a meeting with the FDA, and they're likely going to hopefully approve biomarkers for bleeding risk prediction actually within the next, hopefully, short period of time. So there will be enhanced bleeding risk scores in the near future, but not routinely used in clinics in the United States.